Hi everyone, this is Siring. I'm doing my clinical class case study presentation on pulmonary hypertension. The focus H&P is the chief complaint is dyspnea and fatigue. This is a 55-year-old female with a history of heart failure, red hypertension, heart failure, hyperlipidemia, hypothyroidism, cirrhosis, AFib, recently diagnosed pulmonary hypertension, and scleroderma. So she came to ED with the fatigue, chest pain, lightheadedness, edema, palpitation, and one episode of exertional syncope. Based on symptoms, we are admitting her for the following possible differential diagnosis. Listed five of them. These are her past medical histories we just discussed in the previous slide. Past surgical history is hemorrhoid, allergies, couple of them. Social history, she's videoed smoking, was quit 5 years ago, drinks alcohol occasionally. Family history of hypertension and heart failure in both parents and the sister. These are the list of the medications that she was taking on the day that I was taking care of her. Review of system, fatigue, weakness, otherwise oriented. Skin-wise, she does have very mild skin hardening from her scleroderma to her hand. Otherwise, fairly normal. HENT-wise, reports dizziness when getting up and had one episode of syncope at home. Otherwise, no good. Cardiac-wise, palpitation when EMS was arrived, but denies palpitation at rest now, and mild chest pain still continues. Respiration-wise, dyspnea on exertion, shortness of breath at rest at home, but resolved now. Otherwise, kind of having difficulty catching breath. GI was nausea at times, but no emesis. Otherwise, fairly good. Urinary wise, no problems there. Vascular, she does have edema, which are better now. Musculoskeletal wise, fatigue and feeling weak to the legs, otherwise good. Neurologic wise, appropriate with questions, reports panicking and frustration. She had the loss of consciousness at home, which she remembers. Physical exam wise, appears anxious and mild distress because of shortness of breath and pain. Vitals are fairly stable there. Heart rate is slightly up. Otherwise, uh, breathing a little faster, pretty good. Skin wise, her scleroderma skin is slightly noticeable to her hands. Otherwise, HENT wise, fairly normal. Cardiac wise, no issues at all actually. And pulmonary, diminished breath sounds, shortness of breath with mild breathing distress, crackles and wheezes to the left side. Abdominal wise, fairly normal there. Musculoskeletal wise, weakness to legs, otherwise pretty good. So vascular, lymphatic, genitourinary, and neurologic wise, she is pretty normal. So I won't read every one of them. These are her labs for that day. Fairly not bad at all. White cells slightly up, sodium a little bit down, BUN, creatinine, and alkali phosphates are elevated. Beside that, everything else. The liver function test on that day, everything else is fine. Beside total bili is elevated to 3.3. These are the diagnostic tests we have done for the patient. Chest X-ray is normal, EKG is normal, sinus rhythm. Echo showed she has severe right heart failure, as you can see. Severely enlarged RV, and function is severely depressed as well. Also had moderate tricuspid regurgitation, which means she does have some resistance going on. So all of these indicates we need further workup. Here are the rest of the studies. Pulmonary function test was done. They showed mild restriction. She did a 6 minutes walk and she could only do 325 meters and desaturates to 85 to 84% on room air. VQ scan was done, low probability of CTPH, which is chronic thromboembolic pulmonary hypertension. She's least likely have that. Sleep study was done, was negative. So the gold standard diagnostic test for pulmonary hypertension is the right heart cardiac cath, which showed her right atrial pressure is 5, which the normal is 0 to 5, so she's doing okay there. Right ventricle Also, the pressure was elevated. As you can see, the normal should be, the systolic should be of 15 to 25, diastolic should be 6 to 12, but she's 72 over 7. PA is 72 over 22, so that's very significantly highly elevated. Pulmonary artery pressure is supposed to be less than 25. She is 38. Mean pressure is 38, which is the usually indicates the diagnostic of pulmonary hypertension. Cardiac output and cardiac index are decreased. She's 3.9 and 2.0, but the normals should be cardiac output should be greater than 5 and index should be 3.9. So per pulmonary vascular resistance is 9.4, so there's quite a bit of resistance there. The normal should be less than 3 Wood units, and venous saturation is 51%. So assessment and plan for this patient, she's a IMC level care with confirmed moderate to severe pulmonary artery hypertension with functional class 3 and right heart failure, and most likely her pulmonary hypertension is secondary to scleroderma. Also heart failure can be as well. She does have normal RAP but decreased cardiac output, normal renal function, normal systemic pressure, but functional class 3 because she desaturates with ambulation. The final 3 diagnoses are there. We rule in and rule out based on the test that we did. For the treatment plan for the patient, for her pulmonary hypertension, she is already studied on sildenafil 43 times a day, Valitrib, which is a IV medication for the pulmonary hypertension, and that's a weight-based titration medication. She's on that, and there are some insurance process and teaching specialty for these meds are already studied, and she's getting a Hickman placement for the infusion. Otherwise, cardiac-wise, she does have right heart failure, N828 functional 4. Her edema is resolving now, so we are transitioning her to PO Lasix 40 twice a day. So the rest of the plans we did for the patients are following. She did have pericardial effusion, which she had pericardiocentesis and resolved. AFib is converted to sinus rhythm now, hypothyroidism, home meds. Otherwise, her liver and her scleroderma, she was following with the specialty teams. We were just on the side and treating her symptoms as needed for daily basis. Prophylactic wise, she's on DVT for DVT. She has subacute heparin, GI, PPI. There's a couple of non-pharm supports for her there. Dispo wise, she's full coat IMC level because of Valitrib infusion going on. After all the tests, here comes her final diagnosis, which is a pulmonary hypertension. So a quick short pathophase is that pulmonary pathophase is literally the blood vessels in your lungs are narrowed, blocked, or destroyed. Because of that, the blood flows through the lungs are kind of altered, and blood pressure in the lung arteries are rising up. All this causes the heart works harder to pump blood, and therefore all these pulmonary hypertension patients commonly have right heart failure. As you can see in the picture, the right side of the heart is extensively enlarged, and also her pulmonary arteries are narrowed in the picture down there. So this is pretty much how the pathophase is pulmonary hypertension is indicated. So this is the pulmonary hypertension guideline diagnosis algorithm. I got this picture, the algorithm from the recent guideline of chest, which is American College of Chest Physicians guideline, and which was published updated in 2018. So based on this diagnosis, it's pretty much aligned with what we did for my patient at UW. So it has to be methodological way, methodological way to diagnose these patients with pulmonary hypertension. So based on the guideline studies, so we will approach with history, what are the symptoms, physical exam, chest X-ray, EKG, as we did earlier for my patient. These are your initial diagnostic assessments. Then you do echo, which is a screening testing. It's not a diagnostic testing, it is screening testing. Per they specifically mentioned that. VQ scan is super important, rule in or rule out. CT-PH, which is chronic thromboembolic pulmonary hypertension, which looks different. The perfusion is going to be look different than PE, which is pulmonary embolism. If these patients have PE and CT-PH, this can be life-threatening. That's why it is important to rule out or rule in and treat it. Pulmonary function tests such as ABGs are important. Overnight oximetry. Also, sleep disorder needs to be ruled out. HIV, which is something we didn't do for my patient, but also important to do. ANA, scleroderma, systemic lupus, rheumatoid arthritis. These can be ruled out based on that lab. Pulmonary function, like we talked about earlier, pulmonary hypertension is something that's common that needs to be looked at. Functional test, 6 minutes walk, cardiac pulmonary exercise testing, which is like a stress test sort of. Right heart cath is confirmed. That's the one that confirmed the diagnosis of pulmonary hypertension. So based on the guideline, right heart cath is the golden diagnostic study, and also UW does that as well, so which is aligned. So far, these are the medications that are available for pulmonary hypertension, and it's easier to discuss them in based on the classes. So endothelial receptor antagonists (ERS) are these are the drugs. We'll have three of them. Blocks the effect of endothelin 1, which is vasoconstrictor and metagen. And these drugs have evidence of anti-fibrotic, anti-inflammatory effect. That's the pulmonary function, pulmonary hypertension patients need. And they are effective if patients respond them. Otherwise, it doesn't. So it doesn't work for everybody. Side effects are there as well. There are quite a bit of bad side effects associated with all pulmonary hypertension drugs. These are the rest of the medications in a class: PDE5 inhibitors and SCG stimulators. They kind of work similarly. They both kind of enhance or increase the NACGMP, which is nitric oxide cyclic guanosine monophosphate. It plays a critical role in smooth muscle tone in the lungs, so they try to enhance those to improve the lung function. So as you can see, all these drugs have significant risks associated with them and quite a bit of side effects that we have to be careful about. So I won't read every single one of them, but it's helpful to just go by class-wise. For this case study, I read 2 guidelines, which are super long, but they're very helpful. And I already summarized the findings in the previous slides. Both of these articles are strength is they're up to date, published in the last 5 days, have nice algorithms and tables that are easy to use. However, they are super long and a lot of expert discussions, which are hard to keep short and concise with the short presentation. These are the clinical pulse or take-home messages from this presentation. Overview of my clinical rotation. I was at the advanced pulmonary service at UW Hospital, and most of the patient population I've seen are post-lung transplant, cystic fibrosis, pulmonary hypertension who are waiting for the transplant. And the common cases are there as well, mostly the same. And preceptor-wise, I had total of different 4 preceptors. They all play their own teaching differently, play their own roles differently, but overall I had a good experience at this unit and I've learned a lot. Here are the references. Thank you very much.